I am Dr. Today I am presenting a critical appraisal of an RCT article by using CONSORT checklist under kind supervision of my worthy Professor Dr. Sarah Afzal. This is checklist for CONSORT checklist for the appraisal. This is the title of article: Acceptance and Commitment Therapy plus Usual Care for Improving Quality of Life in People with Motor Neuron Disease, a multi-center parallel randomized controlled trial in UK. Summary: motor neuron disease is a progressive, fatal, and degenerative disease for which there is no cure. Acceptance and commitment therapy is a psychological therapy, integrative acceptance, mindfulness, and behavior change technique. Of ACT plus usual care compared with usual care alone for improving quality of life in people with motor neuron disease, who conducted a parallel multi-center two-arm randomized control trial in 16 UK motor neuron disease care center or clinics. Eligible participants were 18 years to old and a diagnosis of definite or laboratory supported probable, clinically probable, and possibly familial or sporadic amyotrophic lateral sclerosis, progressive muscular atrophy, or primary lateral sclerosis, which met the World Federation of Neurology Ecorial diagnostic criteria. Participants were randomly assigned 1 to 1:1 to receive up to 8 sessions of ACT adapted for people with motor neuron disease plus usual care or usual care alone by a web-based system. Stratified by site, participants were followed up at 6 months, 9 months post-randomization outcome assessors and trial satisfaction were matched to treatment allocation. The primary outcome was quality of life using the MCGIL quality of life questionnaire revised at 6th month and post-randomization. Primary analysis were multi-level modeling and modified intention to treat among participants with available data. This trial was pre-registered with the ISRCT and registry with the number 1265 5391 between September 18, 2019 and August 31, 2024. 35 people with motor neuron disease were approached for the study. A Form 206 were assessed for eligibility and 191 were recruited. ACT plus usual care is clinically effective for maintaining or improving quality of life in people with motor neuron disease. As further evidence emerges confirming the finding, healthcare providers should consider how access to ACT adapted for the specific need of people with motor neuron disease could be provided within motor neuron disease clinical services. Funding: National Institute of Health and Care Research, Health Technology Assess and Motor Neuron Disease Association. Title and abstract. Title: first, identification as a randomized trial. In the title, yes, the title mentioned randomized control trial. Structure: summary of trial design, method, result, and conclusion. Yes, the abstract provide a clear summary of objective, method, and outcome in structured manner. Introduction: motor neuron disease is a fatal neurological disease characterized by progressive degenerative of motor neuron in the motor cortex and spinal cortex, resulting in limb paralysis, dysarthria, dysphagia, and respiratory failure. It affects approximately 4 to 5 individuals per 1 lakh worldwide, and life expectancy is 2 to 4 years following diagnosis. There is no cure, and Riluzole, the sole UK disease modifying drug, extend median survival by about 30%. Because there is no therapy for significant prolonged survival, helping people with motor neuron disease manage their condition, quality of life, and psychological well-being is crucial. This is particularly important as poor quality of life and psychological distress are associated with negative outcomes, including shorter survival time and increased risk of suicide. However, a Paucity of adequately powered randomized control trial means there is a little clear evidence based guidance on what psychological support should be provided. Acceptance and commitment therapy is a psychological therapy that uses a combination of acceptance, mindfulness, motivation, and behavior change technique to assess engagement in life enrichment activities in the presence of distressing throughout and feelings. This approach has been shown to be beneficial for improving quality of life and psychological well-being in order to long-term health conditions which include muscle disorders and chronic pain. We have previously argued that ACT as opposed to psychological therapies such as convention CBT might be particularly appropriated for people with motor neuron disease. There have been no adequately powered randomized control trial for psychological intervention for people with motor neuron disease and none of ACT. Consequently, we aim to assess whether ACT plus usual care were effective for improving quality of life in people with motor neuron disease compared with the usual care alone. At 6 month and 9 month post randomization in a fully powered randomized control trial, secondary aim include examining effect on the depression and anxiety in people with motor neuron disease and indirect effect on quality of life and caregiver burden in caregivers of people with motor neuron disease. In introduction, scientific background and explanation of rationale, yes, the introduction provide a detailed background on motor neuron disease, its impact on quality of life, and the and needs for psychological intervention to highlight in the to highlight the limited evidence from previous studies and explain why acceptance and commitment therapy may be particularly suitable for this population. Specific objective or hypothesis. The article clearly states its primary objective to assess the effectiveness of ACT plus usual care compared to usual care alone for improving quality of life in people with MND at 6 and 9 months for randomization. Secondary objective include examining the effect on depression, anxiety, and caregiver burden. Method. We conducted a multi-center parallel group randomized control trial of ACT plus usual care versus usual care alone. Potential participant was recruited through 16 UK motor neuron disease care center or clinics and via self-referral. People with motor neuron disease were eligible to participate of if age 18 year and older and they met the World Federation of Neurology scorial diagnostic criteria for familial or sporadic amyotrophic lateral sclerosis, a motor neuron disease variant. Individuals were ineligible if they had clinical need for gastrostomy, feeding, or non-invasive ventilation, lacked capacity to provide fully informed consent, and had a diagnosis of dementia. Required treatment for severe psychiatric disorder, expressed suicidal ideation with active plans of suicidal behavior and imminent intent. Had other medical diagnoses that could compromise full study participants. We currently receiving psychological therapy and unwilling to withdraw from their this if allocated to SCT had behavior have previously participated in our feasibility study or had an insufficient understanding of English. Caregiver of people with motor neuron disease were eligible to participate if they were 18 years and older than and were primary formal caregiver of person with motor neuron disease participating in trial. The study was pre-registered with ISRCTN registry on 17 July 2017 and the trial protocol was published. Ethical approval was granted by the London Dolby's Research Ethical Committee, Health Research Authority and Health and Caregivers Wales on June 13, 2019. Oversight of this trial was provided by the Trial Management Group Trials Steering Committee, Data Monitoring and Ethics Committee, and Potential Caregiver Advisory Groups. In method description of trial design, such as parallel factorial, including the allocation ratio, the study is described as a multicenter parallel two-arm randomized control trial with a 1:1 allocation ratio. This is mentioned in the study design and participant section. Important changes in the method after trial commitment. No mention of significant change to method after trial commitment are not explicitly addressed in text. In participant eligibility criteria for participant are provided in detail, including age more than 18 years, diagnosis of MND according to specific diagnosis criteria, and exclusion criteria such as various psychiatric condition or insufficient in English proficiency. Setting and location where the data were collected. Yes, data were collected from 16 UK motor neuron disease center or clinics with site listed to ensure geographical diversity across England, Wales, and Scotland. Procedure. All participants gave fully informed written consent, verbal consent, or consent using communication aids to participate in the trial. The latter two cases, an independent witness verified this. Our consent was audio recorded with the participant agreement. People with motor neuron disease allocated to the treatment group received up to 1-to-1 session of ACT, each lasting up to 1 hour. Over 4-month session were delivered in person via video call or exceptional circumstances via telephone. Session were weekly for the first 6 sessions and fortnightly for the last 2 sessions and were supplemented by online audio material or CD. To assess treatment fidelity, all sessions were recorded using encrypted digital voice recorded with the participant consent. 10% of sessions were randomly selected and assessed for treatment fidelity by two independent ACT trained clinical psychologists and adapted from the ACT treatment integrity coding manual was used to assess the treatment fidelity. This examined the degree to which therapy was consistent with ACT principle adherence to the manual and therapist competence. Sociodemographic and clinical data were collected at screening and baseline before randomization. Assessment occur at baseline 0 and 6 month and 9 month post randomization and were conducted online or in a person via telephone, via video call, or via email by mass outcome assessors. The primary outcome was quality of life in people with motor neuron disease as measured by the total score on the MCGIL quality for life questionnaire revised at 6 months and post randomization. The primary outcome was participant with available data. Secondary outcome at 6 months and 9 month post randomization include existential and psychological subscale of MQLR, hospital anxiety and depression scale to assess the symptoms of depression and anxiety modified for people with motor neuron disease following previous guidelines. Secondary outcome for caregiver at 6 months and 9 months at post randomization were the EQ5D, 5L, EQ, WAS, and Zurich burden interviews. The ZPI assessed whether supporting people with motor neuron disease to engage the ACT placed additional burden on caregivers. These outcomes were assessed in all caregivers with available data for participants with motor neuron disease retained in the study. Measure of bias included credibility expectancy questionnaire adapted for people with motor neuron disease to assess the credibility of the rationale for the therapy and treatment expectations. Treatment allocation preference before randomization, assessment of blindness at 6 months and 9 months for post randomization in outcome assessors. ACT, TICM, and use the psychological and pharmacological therapies to add follow up. Statistical analysis will aim to recruit 188 people with motor neuron disease, 94 per group, to have 90 power to detect the effect size of 0.44 standard deviation with the two-sided alpha of 5% allowing for the 20% attrition and 6-month post-randomization and intra-class correlation coefficient of 0.1 among therapists and a correlation of 0.858 between baseline and 6-month post-randomization for the primary outcome. No minimal clinically important difference has been reported for the MQOL and so the effect size was based on the clinical meaningful pooled effect size of 0.44 SD reported in a meta-analysis of facility for mental and physical health condition versus control. Primary secondary outcome was assessed in the modified intention to treat the population and analyze were conducted separately at 6-month and 9-month post-randomization. Survival at 9-month post-randomization was analyzed using Kaplan-Meier's curve for uh, curves of overall survival and Cox proportional hazard model both with the without random effect of therapist measures of bias and the STTSR were reported descriptively. Several sensitivity analyses were performed on the primary outcome. First, pre-protocol analysis is the subset of the intention to treat population who received at least 4 sessions within a 4-month period. Before 6 months post-randomization, second, a compiler average causal effect analysis in the intention to treat population using modeling to account for compliance with compliance defined as for protocol population. Third, an analysis in the intention to treat population using different multiple population to reduce potential bias due to missing response. 100 multiple imputation database were created using combined equation with included baseline data, treatment group and predictor of missing data to make the missing of random assumptions as plausible as possible. Intervention. The intervention for each group for sufficient detail is allow replication, including how when they were actually randomized. Yes, the intervention SCT plus user care is described in detail, including session frequency, duration, delivery mode, and therapist qualification. Usual care is also outlined following UK clinical guidelines. Completely defined prescribed primary and secondary outcome measures, including how and when they were assessed. The primary outcome is quality of life measured using the MC Gill Quality of Life Questionnaire revised and 6-month post-randomization. Secondary outcomes include depression, anxiety, caregiver burden, and health status assessed timeline. 6 and 9 months and tool are described. Any change is trial outcome after trial commenced with reason. The article does not mention any change to the pre-specified trial outcome after trial begin. Sample size was determined. The sample size was calculation is described aiming the recruit 188 participants with 90% power to detect the effect size of 0.44 SD and accounting for a 20% attrition rate. When application explanation of any interim analysis of stopping guidelines. No, there is no mention in interim analysis or stopping guidelines in the article. Randomization method used to generate the random allocation sequence. Yes, a computer generated pseudo-random list was used to randomization with a block of varying length stratified by recruitment site. Type of randomization, detail of any restriction. Yes, block randomization with varying block size was used, stratified by site, ensuring balanced allocation across centers. Mechanism used to implement the random allocation sequence describing any step taken to conceal the sequence until the intervention was assigned. Randomization were conducted via Sheffield Clinical Trial Research Unit online system. Only authorized individual had access to the allocation sequence. Who generated the random allocation sequence, who enrolled participant, and who assigned participant to intervention. The allocation sequence was generated by the clinical trial unit. Participants were allocated on the baseline data collected before randomization, ensuring proper sequence. Blind outcome assessor and trial, if done, who were was blinding after assignment of intervention. Outcomes assessor and trial statistician were blinded, but blinding were not feasible for participant, caregiver, therapist, and clinician due to the nature of the intervention. If relevant, description of the similarity of intervention, though intervention was not similar. Statistical method used to compare a group for primary and secondary outcome. Yes, detailed statistical method are provided. Multi-level mixed effect model were used, adjusting for baseline scores, age, sex, and therapeutic clustering. Secondary outcome were similarly analyzed. Method for additional analysis such as subgroup analysis and adjusted analysis. Yes, subgroup analysis were conducted to assess the moderation of treatment effect by baseline factors. Sensitivity analysis addressed by missing data. Result participants were recruited between September uh, 18, 2019 and August 31, 2021, 22, with recruitment temporarily halted from March 17 to June 2020 due to COVID-19 pandemic. 435 people with motor neuron disease were approached, and home 206 were assessed for eligible. Of these, 191 were eligible and considered as participant, with 97 being randomly allocated at ACT plus usual care and 94 to usual care alone. Baseline demographic and clinical characteristics for people with motor neuron disease and caregiver are shown in Table 1 and Table 2. Caregiver approach balance across subgroup with no evidence of systematic difference. 42% of 191 patients were female, and 111 were male. The mean age was 63.1 year, and 185 and 191 participants were white or white British. The primary outcome analysis showed that ACT plus usual care was superior to usual care alone at 6 months and 9 months post randomization, with the adjusted differentiation of MQOLR of 0.66 and at 6 months and 0.77 at 9 months, 76 at 9 months. The trend between the baseline of 6 month post randomization was a small increase in MQOLR in ACT plus usual care group, combined with the decline of the usual care alone group. Important, the result of 6 month post randomization was robust to sensitivity analysis using different assumptions for missing response, spotting ACT plus usual care being superior to usual care alone. A post structural equation modeling analysis for the include of the AAQ2 at 9 month and post randomization was conducted. This showed that changes in the MQOLR at 9 month post randomization was mediated by changes in the AAQ2 from 0 to 9 month post randomization, with the indirect effect being significant at 5% level. All other analyses were not significant. This is flowchart and table discussion. We found that ACT plus usual care were superior to usual care alone on maintaining improved quality of life in people with motor neuron disease at 6 month post randomization, and this treatment affect the maintained at 9 month post randomization. Treatment effect size of 0.46 and 0.53 at 9 month post randomization respectively. We are also found significance between groups different in favor of ACT plus usual care for the psychological and existential quality of randomization, quality of life and depression of post both 6 month and 9 month post randomization, psychological flexibility of 9 month post randomization, and brief health status at 6 month post randomization. There were some limitation of the current trial. First, ACT was compared to the non-active rather on than active control condition. This means that observed between group difference in outcomes might have been partially attributed to expectancy or not specific therapeutic factor, such as provision of attention or social support rather than the interventions itself. Future study might consider comparing ACT with such as the previous second participant from the ethical monetary is with represented with most participants self identifying are white or white British. So overfunding cannot be generalized to the broader population. Role of funding. One of the funder of the study, National Institute of Health and Caregiver, result participant for the each group, the numbers of participants who were randomly assigned revised intended treatment and what analyzed for primary outcome. Yes, this point is covered for each group losses and exclusion after randomization together with research with reason. Yes, reason for the exclusion and discontinuation are provided, including death, withdrawal, and unknown reason. There was shown in the flow diagram and described in the text. Data defining the period of recruitment and follow-up. Yes, data recruitment occurred after from September 2019 to August 2021 with temporary halted due to COVID-19 pandemic. Why the trial ended up or stopped? The trial ended up as planned upon meeting the target sample size. There was no indication of premature termination. A table showing baseline demographic and clinical characteristic for each group. Baseline characteristics are presented in table 1 showing balanced demographic and clinical variable across group. For each group, number of participants including in both analysis and whether analysis was original assigned group. Analysis were conducted on the modified intention to treat bias numbers analyzed and reason for measuring data as specified. For each primary and secondary outcome result for the each group and and estimated effect size and its precision. Primary and secondary outcome result are detailed in table 3, which affect the size, confidence interval, and p-value provided with both time points. Primary for binary outcomes presentation of both absolute and relative effect size is recommended. Binary outcomes such as adverse effect and depression progression include absolute and relative effect size where applicable. Result for any other analysis performed, including subgroup analysis and adjusted analysis, distinguishing pre-specified from explanatory subgroup and explanatory analysis such as moderation by baseline depression and moderation by psychological flexibility and discuss sensitivity analysis supported reportless and of primary findings. All important harms are unintended effect in each group. Adverse events are summarized in table 4, including the number of serious events and their attribution related to unrelated intervention. There was no significant difference in human harms between groups. Limitations, trial limitation addressing in the potential bias. The author discussed the trial limitation, including small size subgroup analysis, potential bias from lack of aligning of participant, and challenges in the varying mediation assumption due to a concurrent assessment. They were also mentioned a limitation of COVID-19 release disruption. Generalizability of the trial finding. The authors address the generalizability the interpretation of consistent with result balancing benefits and harms and considering other relevant advice. Yes, it's this point is covered. The other information, registration number and name of the trial registry. The trial registration provided as ISRCTN 1265539 registered with the ISRCTN registry. This information including the method section where the full trial protocol can be assessed. No, there is no mention for protocol availability, source of funding, and other supports. Yes, source of funding mentioned funder has not role in study design in the script writing. Strength of the studies. The overall strength of the studies, the studies comprehensive outcome measures. Primary and secondary outcome, including quality of life, psychological flexibility, and symptom of depression and anxiety, were well defined and clinically relevant. A rigorous methodology randomization was computer generated with stratification by site and masking of outcome assessor and statistician, minimizing allocation bias. Transparency and reporting. The study adheres the CONSORT guidelines, ensuring the transparency in methodology, randomization, and result reporting. Clear, objective, and relevance. The study has a clear and clinically relevant objective to assess the effectiveness of acceptance and commitment therapy in improving quality of life and individual with motor neuron disease. Limitation, lack of blinding. Participant caregivers and clinicians were not blinded due to nature of the intervention, which could introduce performance bias. Missing data and sensitivity analysis. Although multiple imputations were used to address missing data, the imputation of data being missed at random could introduce bias. Generalizability results are based on the UK healthcare system and may not apply to countries with different care frameworks. Limited focus on adverse events. While on no serious adverse events were attributed to ACT, the reporting of social stresses were higher in the intervention group, raised questions about potential subtle harms. Focus on psychological harm measures. The study primarily targeted psychological and quality of life outcome, leaving gaps in understanding psychological, physical health impacts. Uh, this is our YouTube channel. This is a link for our YouTube channel, and thank you.